Okay, we're here today with Tig Lane, who's an active expert by experience for the Radiant Network. Tig utilises his personal experiences as a relative of a person with intellectual disabilities and associated health needs to educate health professionals through improving services, providing training opportunities, and creating ideas for research. So, Tig, thanks so much for joining us at the first Trauma and Neurodiverse Populations Conference. To start with, could you tell us a little bit about your brother?
Yeah, of course. So my brother is called Nathan. We're twins, so we're about 31 years old. Um, so Nathan's sort of journey really sort of began sort of after he sort of left formal educational system is when he sort of started to have difficulties in the community really, particularly around his care needs and mental health. It wasn't until he sort of formally entered the care scene once he was an young adult, really that we noticed that he was becoming to struggle more and more in the community due to what we sort of now know was due to his anxiety. This then progressed on as unfortunately placements continued to break down, which sort of led to ultimately his final placement before being admitted to an assessment and treatment unit. During this sort of intermediate period, he was placed on a drug called olanzapine, which greatly improved his lucidity. It helped reduce his anxiety, especially around social situations when he's doing his activities out and about in the community. And Unfortunately, he was then removed off of that rather suddenly, and we then noticed a sharp increase in his anxiety levels, which then led to his admission to the assessment and treatment unit, where after his second admission, he was then finally prescribed the olanzapine on a trial basis, and we then noticed a significant improvement in his condition.
Okay, thank you for that. So you've spoken a little bit about Nathan and his journey onto medication, and then some of the difficulties that followed after that. We're here today talking about trauma and neurodiversity, so trauma, autism, and learning disabilities. Obviously, we all go through traumatic events in our lives. Would you say that your brother reacts to those kinds of events as we might expect?
So Nathan definitely doesn't react to events that we would perceive as traumatic, how a neurotypical person would. A recent example I can think of is a couple of years ago, our granddad passed away unexpectedly. Nathan was told, and he was he was invited to the funeral and he attended. He even saw granddad's grave and granddad getting buried. But he seemed relatively happy, quite content throughout the whole process. I do believe he understood that granddad wasn't around anymore. I don't know if he fully comprehends the concept of death, but even so, he didn't seem distressed at all. In fact, I think he was enjoying his sort of day and get to see family members, even though it was a sad situation. This is in stark contrast to an incident when we were kids during the Millennium Dome celebrations in 2000, where he was very, very distressed as soon as we almost arrived, really, to the event. There was lots of people around, which I think significantly increased his anxiety levels. There was lots of noise, lots of lights, lots of various different unusual exhibitions going on, and that was just outside. Inside was even more condensed, so you had all those various elements, but in a much smaller space, and that was just too much for him. He was crying, screaming. He just wanted to get out. He was trying to physically run out of the place. He just was not happy at all. So, in my opinion, it seems like he had quite a traumatic experience. He found that experience very traumatic, which is again a very atypical presentation to someone who was neurotypical. whereas my sister and myself, we absolutely loved it. And again, that's just quite a stark contrast really to the bereavement. There was also another instant when we were kids as well. There was a milk advert on the TV at the time, and the milk bottles would get up and sort of walk off down the street. And Nathan also found that very distressing and quite traumatic. He would end up going around the different houses in the neighborhood, pick up the milk bottles and smashing them, as he genuinely found that just that advert alone very distressful, because he genuinely believed that the milk bottles would get up and try and walk away.
Thank you for that. So it sounds like the types of experiences that your brother perceives as traumatic might not be the same as the sorts of things that you or I might find traumatic. So how do you go about predicting how he might react to a certain situation, or understand what is triggering him when there is no immediately obvious trigger?
That's a really good question. So Nathan does have communication difficulties as part of his ASD. Um, so whilst he's able to communicate verbally, it is very limited and in very improper sentences. So he isn't able to put across how he is feeling or what he is thinking. An abstract concept he does really struggle with. So he's not able to verbally communicate. So what he does rely on is our ability to interpret him. So we know Nathan really, really well. I've known him all my life, 31 years, as a mum and dad as well. So we use that experience of Nathan and all the past experiences we've had with him to formulate almost educated guesses on what he does find traumatic, what he doesn't find traumatic, what experiences he will and won't like, and then how he will likely react in those places. Because we can't read minds, we don't know exactly what he is thinking or feeling, and he isn't able to verbally express that to us. We have to use our past experiences as well as then interpreting his own behavior change, his own changes in behavior, as well as how he interacts with his environment. So when his placement was breaking down in the community at his care placement, he ended up damaging his environment almost as a cry for help, just to try and make it his expression just how distressed he was. He'd also damage his own property, I think, to try and reduce the stimulation levels in his environment, because he was he was so distressed, he was just finding everything so overwhelming. So he had a radio in his room which he destroyed. He'd then also remove items out of his room as well, so any photos or toys would be posted out the window. So those various changes in behavior is how we would sort of give those indications that Nathan may be distressed or being undergoing some sort of trauma.
You've talked a little bit about Nathan's mental health and how sometimes his behaviour changes. Can you remember when things got to the point where medication was first being explored as an option for Nathan, and how that made you feel as a family?
Yeah, so I think medication, again, like I said earlier, probably around the time he was in like early adulthood and the first couple of placements had broken down, his mental health had seemed to start deteriorating. It was becoming more and more anxious. That's when the discussions first started, but we were quite apprehensive about Nathan being medicated, as we were concerned about possible side effects, particularly personality changes. Because we love Nathan how he is, we just wanted his mental health conditions to be treated. We didn't want Nathan to change. So we just wanted him to have the same access to healthcare and treatment that we ourselves as neurotypical individuals would have anyway. Um, we're also concerned, a side effect we were concerned about was any sedation. We didn't want him to lose his alertness at all. We want him to be himself, just without those the mental health conditions having those negative effects on his own well-being. Um, yeah, we just want to make sure that he was still out to have those treated, so he was able to then live a full life in the community and have that good quality life that he deserved.
Absolutely. And when he went on to the medication, did you realise that it was working or that it wasn't working? What sorts of signs were there at that time?
So at that time, we noticed positive a positive impact in his ability to process information. His thought bandwidth seemed to increase, so he was able to cope with multiple stimuli and process that without becoming overwhelmed. So he was able to go out into the community, for example, whilst family members such as myself would be able to talk to him, and he'd be able to cope with that and actually enjoy himself. Whereas when he was before he was put on the olanzapine, and then once he was removed off the olanzapine, he struggled um, significantly with being able to go out in the community, let alone then with the input that family would have of him. So we'd ask him questions, or would you like to go here, Nathan, or what would you like to eat? When he wasn't on olanzapine, he'd struggle significantly with that, which also then plays into his lucidity of thought. Whereas he would normally on the olanzapine, he was able to think. And when we'd give him a question and give an appropriate response, whereas off the olanzapine, we noticed that he was struggling a lot more with just trying to process his own thoughts amongst all the external stimuli as well. So he was definitely struggling with formulating that appropriate response, which he didn't struggle with when he was on the olanzapine.
Thank you. And as a family, have you had any negative experiences with prescribing and medications for Nathan?
Yes, so I do think it is important though, just to explain that just because of our experiences may have been negative or haven't been ideal all the time, doesn't necessarily mean that everyone will have these experiences. And just because we've had positive experiences with medication doesn't necessarily mean that that will be the case for everyone. It is definitely a very personal decision and circumstance on who will benefit. And I definitely think that's a discussion that the patient, the individual with those conditions, their family members, and the clinicians involved need to have amongst themselves to try and work out the best possible outcome for their family member. So I can appreciate lots of family members, like as we were ourselves, are concerned about overprescribing of drugs as well as the side effects of those medications. So I mean, our experience particularly was Nathan was suddenly removed off of his olanzapine after being on it for a year or two initially, the first time round, and this came as a surprise to us as we feel like we weren't properly consulted by the clinician who made that decision, especially as Nathan, as far as we could observe, wasn't experiencing any significant or any real negative side effects at all. And his quality of life was very high, so he didn't really see the need of why there needed to be a sudden removal of the drug at all, really. That then resulted in quite a steep mental decline in Nathan's mental and physical health. He began to lose weight very rapidly. Um, he was withdrawing socially, so he was going out less and less in the community, to the point that he was struggling even to go out with family members. So so he was really struggling. Um, Mentally. That then led to his placement starting to break down, which then led to his first admission to an assessment and treatment unit. Um, there he received the appropriate quality of care. So he didn't actually exhibit any sort of overt symptoms or signs of mental illness. So understandably, he was then discharged back into the community, where unfortunately again his condition continued to deteriorate until his second admission to an assessment and treatment unit, where he was then finally placed back onto the olanzapine and on a trial basis, which then significantly improved his mental and physical health.
Okay, so given all those experiences, do you have any last thoughts that you'd like to leave the audience with in terms of best practice around prescribing, especially where the mental illness isn't clear cut or unknown?
Yeah, absolutely. So I'd like to make it clear that just the significant impact that a sudden change to prescribing medications, even well, even though almost certainly maybe well intentioned, it can have quite a significant negative and detrimental impact if it's not made in consultation with the patient and their families, and it isn't carefully monitored, especially in a community setting. Um, as unfortunately, as Nathan is a prime example of, this can then lead to a significant deterioration in the patient's mental and physical health. So I personally think almost a scientific methods approach would be beneficial. So where medication change is proposed and agreed between the family, the patient and or the family and the clinician, um, then instigating that change on a trial basis whilst carefully monitoring the patient's condition, if there are any benefits or negative effects as a result of the medication change, and then evaluating it at the end of that trial period to then determine the pros and cons of the medication, uh, and then have a discussion with the patient and then the family members on whether they feel it would be beneficial to continue or not, and then have a collaborative approach between the clinician and the family members. I really do think would have a very positive impact. So that sort of nicely brings me on to my second point, really, which is involving the person who's directly affected, so the patient directly in their care, in the whole decision-making process where possible, especially where medication changes. And if that's not possible to involve the patient themselves, then to involve either family members who know the patient very well or another appropriate advocate who can then advocate for the patient's best interests and then work collaboratively with the clinician to try and formulate a treatment plan that would have the best possible clinical outcomes for the patient. And then, really lastly, just to sort of summarize everything I've said, I do genuinely believe that clinicians are the clinical experts of their field. They are fantastic in my experience, but family members are experts in their family members and their needs, both care, mental, physical, and all aspects. So I do think a collaborative approach between family members or advocates and the patients and clinicians involved in the treatment, that's where you can get the best possible clinical outcomes for the patient and make a real positive difference and have a positive impact on that patient's, that individual's quality of life, and really have an impact for the better.
Well, thanks so much, Tig, for sharing your experiences with us here today. It's given us lots to think about regarding the role of prescribing medication when we are faced with these clinical situations where the person's in distress. There's some complexities around the diagnosis, and really giving us some best practice considerations to think about as well. And we're now going to explore some of these ideas further within the panel discussion. And we're so sorry that you can't make it to be with us live and in person, but
As
thank
am
you
I.
so much for your time in recording this video for us. So thanks again, Tig.
And thank you very much for the opportunity.